Hi, my name is Viana, and I'll be a provider interviewing you and performing your physical exam today. Can you please tell me your name, your date of birth, and where we are?
Gianna, June 29th, 1998, North Hoboken.
The patient appears to be awake, alert, and oriented times 3. Can you please tell me your pain on a scale from 0 to 10?
0.
The patient appears to be or is in no acute distress. Their affect is appropriate to the situation. Their skin appears to be pink and well perfused. Next, we'll move down to the head and face assessment. So first, I will inspect the scalp, looking for any redness, bumps, or lesions. The scalp is free of any redness, bumps, or lesions. Her face appears to be pink and well perfused, also with no bumps or lesions noted. Next, I will assess her facial symmetry. So can you please smile, frown, puff out your cheeks, open and close your eyes. Cranial nerve 5 and 7 are intact. The facial features seem to be symmetrical bilaterally. Next, I will palpate your scalp. Any pain or tenderness?
No.
Patient denies pain or tenderness to palpation. No bumps or lesions felt upon palpation. Next, I will assess your facial sensation. So can you please close your eyes? And then when I tap your face, let me know if it's the sharp side or the dull side poking you.
Dull. Sharp. Sharp. Dull. Sharp.
Cranial nerve 5 is intact. Facial sensation is normal. Next, I will palpate your masseter muscle. Open and close your mouth. No popping or clicking noted. Any pain or tenderness?
No.
Denies pain or tenderness. Next, I will palpate the temporal muscle. Any pain or tenderness?
No.
Denies pain or tenderness. Next, we'll move down to the eye assessment. I'll first inspect her eyes for symmetry and hair distribution. So the eyebrows have hair evenly distributed bilaterally. Eyelids are free of any redness, swelling, or lesions. Bilaterally, the eyelashes are also distributed bilaterally. The sclera are white bilaterally. The conjunctiva are pink and moist, and the lacrimal apparatus is also moist bilaterally. Next, I will assess her extraocular movements. So just look forward for me and then follow my fingers. Cranial nerves 3, 4, and 6 are intact. No nystagmus, strabismus, or lid lag noted. Next, we would dim the lights. I'll put down the shade. And we will assess her corneal light reflex with the ophthalmoscope. I'll use my right hand to look in the right eye, and we're looking to see that the light shines symmetrical on the other side, which it did for the right eye, as well for the left. So both eyes bilaterally are positioned and aligned. Next, I'll assess cranial nerve 3. So just look forward. And cranial nerve 3 is intact. Pupils are equal, round, react to light, and accommodate. Next, I will do a fundoscopic exam. So again, with my right hand, I'll look in the right eye. Noting the optic disc, red reflex, and retinal background. Again, left hand to left eye. Again, noting the optic disc, red reflex, and retinal background. There was no exudate lesions or hemorrhaging noted to the retinal backgrounds bilaterally, and no retinopathic changes bilaterally. Next, we will turn the light back on. And I'll test visual acuity with the handheld Snellen chart. So I'll stand 6 feet away with doing the cover test. So can you please cover your right eye with your right hand and read the smallest line that you can.
LTFPH.
And same with your left eye.
LTFPH.
The eyes have 20/20 vision bilaterally. Next, we will move down to the ear assessment. The ears are symmetric in size and shape bilaterally. where you have any lesions, redness, or drainage bilaterally. Next, I will palpate the auricle and the tragus, or the pinna and the tragus. On each side, any pain or tenderness? No pain or tenderness noted. So then I will examine the internal auditory canal. So I will use the otoscope in my right hand to assess the right ear and pull the pinna up and back. Noting the tympanic membrane being pearly gray with a positive light reflex. And same on the left side, with my left hand pulling up the left ear, or the left pinna up and back. And then tympanic membrane is pearly gray with a positive light reflex. Next, we will assess hearing acuity. So first, I will perform the whisper test. So just repeat after me with what I whisper.
Apple. 1, 2, 3.
Okay. Next, we will assess bone conduction with the Weber test. So just let me know when you stop feeling the vibration.
No.
Okay. And now we will assess bone conduction to air conduction with the Rhine test. So let me know when you stop hearing it.
No.
And then I'll place it on the mastoid process and let me know when you stop hearing it.
No.
Same on the other side.
No. No.
Next, we will move on to the nose assessment. The nose appears to be midline and symmetrical to the rest of the face. No redness, lesions, or drainage noted on the nose. I'll then palpate her nasal bridge and the soft tissue. Any pain or tenderness?
No.
No pain or tenderness noted. Then I'll palpate the frontal and maxillary sinuses. Any pain or tenderness?
No.
Denies pain or tenderness to palpation. So then we will examine the nasal canal with the otoscope again. The nasal mucosa appears to be pink and moist. No lesions or polyps noted. No drainage noted. The nasal turbinates are intact. Both nares are painted bilaterally, and the nasal septum is intact. Next, I'm going to have you close your eyes, and we're going to do the smell test. So just occlude your right nare. And then on the left side, in 1 second, let me know what you smell.
An orange.
Okay, and keep your eyes closed. And switch nostrils. We're going to do the same thing. Let me know what you smell.
Indigo.
Yep. Alright. Next, we're going to move on to your mouth assessment. The lips appear to be pink and moist bilaterally. No lesions or bumps noted. Alright, can I please have you open your mouth? 32 adult teeth intact, no odor noted. The buccal mucosa is also pink and moist. The gums are pink and moist. Can you stick out your tongue for me? The tongue is pink and moist with no lesions noted. I'm going to stick it out a little further. Say Uvula is midline. Can you say DLNT?
DLNT.
And then I'm just going to do a little gag reflex. Sorry. Cranial nerves 9, 10, and 12 are intact. Just look up for me. Open. The hard and soft palate are pink and moist bilaterally. Next, we're going to move on to your neck assessment. So I'm just going to have you scooch a little forward. So yeah, that's good. All right, the neck appears to be midline. Can you look up, down, left, and right? And then ear to each shoulder. The neck has full range of motion. The trachea also appears to be midline and no tracheal deviation is noted. And then I will palpate the lymph nodes, so let me know if you have any pain or tenderness. We'll do both sides. The preauricular, the postauricular, the occipital, the tonsillar, the submandibular, and the submental. Any pain or tenderness?
No.
And the superficial cervical. Any pain or tenderness there?
No.
Patient denies pain or tenderness to palpation, and the lymph nodes are soft and mobile. Next, I will palpate your thyroid. Okay. No thrill noted. Then I will individually palpate the carotid arteries on each side. It's about a 2+ bilaterally and no thrill noted. Then I will listen to the thyroid and carotid arteries for any bruise with the bell of my stethoscope. No bruise heard over the carotid arteries or the thyroid. Next, I will have you try to turn your head to the left and then to the right. And now shrug your shoulders. All right, cranial nerve 11 is intact. We're going to move on to your posterior chest assessment. So I'm going to have you sit this way, and can you just lower that? Yeah, perfect. I'm going to move your hair. Move back a little. Okay. Yeah, that's good. All right, can you please take a deep breath? The posterior chest appears to be pink and moist and pink and well perfused. There's easy, even chest rise and fall noted. Take a deep breath one more time. Symmetrical AP diameter, diaphragmatic excursion is also symmetrical on both sides of the chest. The respiratory rate is easy, even, and unlabored, around 12 to 20 respirations per minute. Next, I will palpate for tactile firmness. Say 99.
99. 99. 99.
Tactile firmness is not noted over any of the lung fields. Next, we're going to percuss in at least 3 lung fields. And then over the right lung a little. So resonance is noted over all lung fields. No dullness was present upon percussion. Next, I'm going to auscultate again in at least 3 lung fields with the diaphragm of my stethoscope. You can move up a tiny bit. No, other way. Yeah, that's good. Lungs are clear to auscultation bilaterally, no adventitious breath sounds noted. All right, now we'll do the anterior chest, so you can do the same thing, just turn around. Okay. The anterior chest is also pink and well perfused. Take a deep breath. Easy, even, chest rise and fall noted, symmetrical on both sides. Now I'm going to palpate the anterior chest. Again, the respiratory rate is easy, even, and unlabored, anywhere between 12 to 20 respirations per minute. Let me know if you have any pain or tenderness.
No. 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 No.
Okay. And then we will auscultate the anterior chest. Lungs are clear to auscultation bilaterally, and then we will move on to the cardiovascular assessment. Right, position change. The patient is now supine for the cardiovascular exam. Can you look left? We're assessing for JVD with the pen light. No JVD is noted. Next, we will also take all heart sounds, listening for any extra heart sounds such as S3 or S4, any split S1 or S2, and I'll listen for both high pitch and low pitch sounds with the diaphragm and the bell. So first I'll listen with the bell starting on the right sternal border, second intercostal space in the aortic bell, and then moving down to the third and fourth intercostal spaces for the pulmonic and the tricuspid, and then over to the fifth intercostal space midclavicular line, the mitral. And then I'll do the same with the bell, aortic, pulmonic, tricuspid, and mitral. Next, I'll palpate the point of maximal impulse, which is also at the fifth intercostal space midclavicular line. Easy even heart rate is noted, which would be 60 to 100 beats per minute. Next, I'm going to assess the aortic, renal, iliac, and femoral arteries. So I'm just going to roll this a little. There's no bounding pulses noted to where the aorta, iliac, or renal arteries would be. Next, I'm going to palpate to see if I feel any bounding pulses. No bounding pulses noted. At the same time, when I'm palpating the femoral arteries, I can also feel for any lymph nodes, and there's no lymph nodes noted at this time. Next, I will also take the same arteries with the bell and the diaphragm, listening for any bruits or thrills or any abnormalities. No bruits heard. Also back to auscultation of the heart sounds. There were no abnormal heart sounds, no S1 or no S3 or S4, split S1 or S2, or turbulent blood flow noted. So now we'll move on to the examination of the lower and upper extremities. This angle. Yep. Both lower extremities are equal in color bilaterally. No edema noted to inspection. Hair distribution is equal bilaterally and appropriate to the patient's situation. Now I'll palpate for any edema. No edema noted. Then I'll palpate bilaterally the posterior tibialis pulses, which are equal in 2 plus bilaterally, no thrills. Then I'll do the versalis pedis pulses, which are also equal and about a 2 plus bilaterally. Then I'll assess capillary refill in at least 2 digits on each extremity, which is less than 3 seconds on the right foot, and less than 3 seconds on the left foot. Next we'll move up to the upper extremities. Both upper extremities are equal in color bilaterally. Hair distribution is evenly distributed across both extremities. I'll palpate the radial pulses. Radial pulses are 2 plus bilaterally. And next I will assess cap refill again in both hands, at least 2 digits. In the right hand, cap refill is less than 2 seconds. In the left hand, the cap refill is also less than